This is LiveWell Talk on psychological approaches to chronic pain. I'm Dr. Dustin Arnold, Chief Medical Officer at Union Point Health, St. Luke's Hospital. Returning the podcast today is Dr. Benjamin Tallman, a pain psychologist with St. Luke's Rehabilitation and Pain Center, to discuss how psychological treatments can help patients who suffer from chronic pain. Dr. Tallman, welcome back.
Dr. Arnold, great to be here. Nice to see you.
Yeah. Before we get, psychology, people, think, oh, I'm crazy. I have to go see a psychologist for chronic pain, depression, whatever condition. It reminds me of that joke. What did the orthopedic surgeon tell the psychiatrist who broke his leg skiing? It's all in your leg. You've never heard that joke? No. It's kind of a doctor lounge joke, but there is make it okay, mental health, et cetera, et cetera. There is a stigma to request mental health that, oh, my doctor must think I'm crazy. So before we get into the program of that, how do you overcome that with a patient?
Yeah, great question. The biggest thing is just getting patients to the clinic itself. As you've noted, unfortunately, there continues to be a tremendous stigma in this country surrounding mental health issues. And then I think it's kind of a double whammy for chronic pain because we've taught patients and people so much that pain, to focus on the severity of their pain, and that we treat pain through pharmacologic interventions, through medications, through injections, etc. And that's really the method, is to get rid of the pain. Again, that works really well for acute pain management, but it really fails time and time again for chronic pain management. We are not going to typically get rid of anybody's pain, all of it. Again, I'm not against pain reduction, and I'm not against medications or injections. These are all very, very important tools for quality of life to be able to take the edge off. But when we talk about chronic pain and psychological approaches, it is way more complex than just somebody talking about the number of their pain severity. We start talking about the neuroscience behind pain. And that's really where psychology comes in, is my training really sits at the intersection of kind of general psychology and medicine. And you have this area called, neuroscience, where it's really how does the brain communicate with the body and vice versa. So, why would somebody with chronic pain ever see a psychologist? And I would say that if you do have chronic pain and you've never seen a psychologist, then you're not getting the gold standard treatment. You're not getting the best treatment. And I think the patients that have had chronic pain for many years that are listening to this that haven't seen a psychologist will know that, because they're still really struggling with the day-to-day associated with chronic pain. So why psychology? Why stigma? Again, that's part of our country. It's difficult for us to want to seek help, especially here in the Midwest. I grew up in a small farming community. There's very much this pull yourself up by your bootstraps mentality. If anybody knocks on your door and asks for help, we're the first person to go and help them. But we're typically the last people to go and knock on somebody's door. So our hope is that, and one of the unique things that we're doing in our Rehab and Pain Center is really demystifying chronic pain, destigmifying chronic pain, and really helping not only our providers in the Unity Point system, but really helping our community understand that we need a different paradigm. We need a different perspective how to treat chronic pain. And it's not just treating severity or getting rid of pain, because we know that does not work. When the treatment goal is to get rid of the pain, you will fail almost 99 out of 100 times. That leaves the provider frustrated. It leaves the patient frustrated. And we're not going to get rid of pain, because pain, and whether it's emotional pain or physical pain, and I don't differentiate between the two. Certainly there are specific health conditions like diabetes that leads to diabetic neuropathy, where there's actual damage to nerves, where people can experience pain related to misfiring. But when you look at how pain is processed in the brain, the physical side of pain and the emotional side of pain, you can't disconnect them. But yet we try all the time. And I love to use the example. I like to do home renovations. So if I'm at home and I hit my thumb with a hammer, what's the first thing that I'm going to do? Typically, if I hit my thumb with a hammer, what am I going to do first?
Scream.
I'm going to scream. And depending on whether my kids are present or not, I might use some choice words, right? So I'm going to scream and I'm going to say something. And then I'm immediately going to grab my thumb and start rubbing it. And I'm doing this because though I've had this zinging sensation from these fast twitch nerve fibers that are carrying signals up myelinated nerves. I start rubbing the areas that basically are running interference that goes up to my brain, tells me what to experience. And then I'm going to start saying things to myself. I'm going to say, oh, you idiot. Why did you just hit your thumb with the hammer? Why weren't you more careful? So now I have an emotional, so I have a cognitive response, I have a physical response, and now I'm frustrated or I'm angry. Or let's say I really do it. Let's say I really bang my thumb and I split it in two, and now I got to come to the St. Luke's emergency department. And now I'm saying to myself, wow, how am I going to be able to finish this project? How is this going to lay me up? How is this going to impact my day-to-day, right? So we try to treat pain by just focusing on the severity or the sensation of pain when you cannot uncouple the thinking patterns, the behavioral patterns, the emotional reactions, all these biopsychosocial factors. And essentially that's why psychology is so important to chronic pain management. And really, that's what we're trying to help demystify. Pain is not all in people's heads. People feel pain in their body. Pain is processed in the brain. I think I see over 1,200 patients a year, from my last statistics, probably more than that. In the last 15 years, I think I've seen one or two people that have faked it. It is extremely, extremely rare that somebody is faking their pain.
Yeah.
Everybody that walks through my doors, I believe them because their pain is absolutely real.
Yeah. Dr. Matthew and I had a podcast of recent, and we talked about that in my 27, 28 years of practice, I don't ever recall seeing someone that was clearly malingering for secondary benefit.
It is rare.
Yeah. Which I think that's a lot of times patients say, oh, the doctors think I'm crazy. No, they just don't know what to do for you. I think Correct. As physicians, we all understand, no, the patient really believes what's happening. This is not, they're not lying to you. We lie about our diets and how many cigarettes we smoke and alcohol we drink. Patients lie about that all the time. But no, these are real symptoms because nobody wants to have to spend their day in a waiting room to see a physician. This is real. That's so important to stress. I think that's a great point to make. As we spoke on a previous podcast, that patients may say, I have a high pain tolerance, low pain tolerance. And as I said, and you confirmed, you have your pain tolerance, right? So everybody's an individual. How do you address that as far as the different psychological aspects of pain? And I'm sure not patient A is the same as patient B. So how do you approach that, Dr. Tallman?
Yeah, great question. Every patient that comes into our clinic has a unique genetic profile, biological profile, psychological profile, cultural profile, spiritual profile, right? So somebody doesn't fit nicely into one category. And the treatments that we provide in our clinic really help to cater to people from all different walks of life. And the commonality, though, is the suffering. Anybody that has experienced physical pain, and often many of my patients that have histories of chronic pain also have histories of trauma. It might have been abuse at an early age. It might be a car accident, but the vast majority have some type of trauma history. And they've suffered, and they're continuing to suffer. So, everybody suffers a little bit differently, but when you get a number of people into a room, and all of our treatments are group treatments, it's really a population-based care model, and you get people in the same room, there's a shared experience of being able to relate to somebody else who is going through it. Yeah. And oftentimes when patients go and they see me or you, and we don't look like we're in chronic pain or we're struggling, the patient has a very difficult time relating to us or believing that we are relating to them. So even though everybody's very different and has an individual pain profile, being around other people who get it, who understand it, might not be their exact same experience, but really there's this shared understanding of I've suffered, you've suffered, and it helps me to understand and know that I'm not the only one that's going through this.
I mean, I've said this, that what is the whole purpose of the internet in simplicity? It's for human beings to connect with other human beings that have similar interests, likes, dislikes, political views, social views. I mean, that is, in summary, that's what the internet does, right?
Absolutely.
Social media connects you with people that you're not alone, which that's a great message to send.
Yeah, part of what we're trying to accomplish is, from that social piece, is having people connect. And, I think part of the secret sauce, or why we have the outcomes that we have, and I can go through some of the different treatments that we provide, but we don't do a lot of individual treatments. If somebody wants to come and see me in clinic, I'd be happy to evaluate them for, typically it's a 30-minute evaluation to get some information. But it's very common for people, even though we're social animals, to feel anxious, to feel fearful of, am I going to have to spill the beans and to share all this information about myself? And what people realize is that once they come to one or two of those sessions, that anxiety just kind of goes away and is replaced by a sense of connection, right? We work ourselves up. We have this set of expectations about life. We have a set of expectations about pain. We have a set of expectations about all things in this world. And that set of expectations, or the thoughts that we have, prevent us from living life. We live life oftentimes thinking about what's going to happen in the future or what's happened in the past. When we think about traumatic experiences or challenging experiences, these are memories that when people think about, they become the present moment reality. So people are reliving these traumatic or painful experiences again and again and again. Part of what we're trying to accomplish with a number of the interventions that we're using is help people break those types of thinking patterns that are increasing the experience of pain. Some people are like, well, why would psychology, how does psychology help with, me changing my pain level? What is that going to help my pain severity? What the type of treatments that I provide are the type of thinking patterns, behavioral patterns, and emotional patterns. They increase the experience of pain, or as I call it, they contaminate the experience of pain. Example I used recently is my daughter's at the trampoline park. She's 5. She rolls her ankle. And she doesn't have this lifelong perspective of what it's like to be disabled or what it means to have hurt herself. She gets up, she starts jumping on the trampoline on the other foot. Okay? It's a pure response to an acute pain perspective or acute pain reaction. Many people with chronic pain, when they have had that pain for an extended period of time, and they've thought about, you've mentioned isolation. I'm sitting at home. I can't, my life is now over. I can't work anymore. My social connections are gone. I feel depressed. I should be able to do the things that I was once doing, right? So people get in their heads and are thinking about all of these things, and then they create this story that they tell themselves about their pain. Again, the pain is very, very real. And the story that they tell themselves continues to cause more distress in their lives. Versus my daughter, gets up, she runs around. She hasn't created that story about herself. We oftentimes create a lifetime of these narratives based on previous traumatic experiences, cultural factors, what people have told us about how we should manage pain, right? So a lot of the interventions that we use try to break those patterns, these long-standing patterns of expectations that we have about of ourselves, expectations that we have about other people. And really what we're trying to do is free people from themselves. We are the ones that hold us trapped in ourselves, and oftentimes we're the ones that are holding us trapped with our chronic pain.
What is... Oh, let me ask you this. Do you ever have a patient that's refractory, like they never really get comfortable in the group setting, or is it pretty universal they do?
The vast majority of time, patients their anxiety decreases. Now, I do certainly have some patients that don't end up, completing the group for whatever reason, but I've had patients with significant debilitating anxiety. I mean, debilitating, that have made it through their group, and at the end, they're different people. We have 3 groups in our program. So our program takes 6 months to complete. It's 24 sessions. And 24 sessions may seem like a lot of time, but it is not. The first 8 weeks is cognitive behavioral therapy for chronic pain. This is the gold standard treatment, most research support for cognitive behavioral therapy and pain management. And what CBT does is it gives people the foundation, a foundational set of coping skills to be able to do the tough work. So we're going to teach people to meditate, which is extremely important to help them begin having a different relationship with their thinking patterns. We're going to help them start to break some of these other patterns. But really what CBT does is it helps to curb the beliefs that we have about ourselves that are causing distress. I'm a bad person. I'm a bad husband or father. I'm worthless. I'm a failure. Right? We have these core beliefs, and then we have automatic thoughts. We become the thoughts that we have about ourselves. Right? So we become these thoughts, and we use evidence to support these thoughts about ourselves. And the vast majority of the time, the evidence is not accurate. We might say, I'm bad because of this, and this. But when we look at the evidence, we can see that there's not evidence to support that. So CBT curbs the core beliefs and helps people start to understand that they're not as bad a person as they think. The second group is clinical hypnosis. This is an evidence-based treatment. It's a research protocol that I use from a colleague at the University of Washington. Out of all the pain management treatments, let me back up a little bit. Cognitive behavioral therapy is not specifically designed to decrease pain. And when I tell people that, they're a little disappointed. I get great outcomes with significant decreases in anxiety and depressive symptoms, which then we sometimes see a decrease in pain. Clinical hypnosis is a treatment intervention that is specifically designed to decrease an individual's physiologic response to pain. When you look at all the literature of all the medication interventions and all the psychological interventions, clinical hypnosis has some of the best research for decreasing the experience of pain. I'm not tracking some of these outcomes, but I bet 20 to 40% of my patients, they go off some of their medications for pain and for sleep. And for many of them, their pain level goes down. But what's really interesting about hypnosis is that's not even the most powerful aspect about the modality. We live in what I call the muck. It's the thoughts, it's the feelings, it's the emotions, it's the previous traumatic experiences that we live in day to day. It's kind of like having your blinders on like this. And what hypnosis does is it allows us to kind of cut through all the conscious muck and allow people to connect to themselves in a way that maybe they've never connected before. Maybe for some people, and a lot of this is based on their beliefs or their preference. Sometimes it's connecting to a religious belief, sometimes it's spiritual, sometimes it's a higher power, it could be connecting with nature. But people begin to learn about themselves in ways that they've never learned about themselves before because of all the pain, all the muck, everything else. So we look...
Or I think it's a little bit just human nature, though, that you don't... I just had a book do a lot of reading, and a book was given a season in life. And it's a football book, but it's about this football team and et cetera. But, I came across something there. I was like, oh, that's why I do that. That's why I feel that way about it. You wouldn't think at my age you'd be discovering why you do things or why you feel things that way. So it doesn't surprise me that people either haven't dedicated the time to thinking about it or have just went through life without thinking about it.
I think most of us, in many cases, go through life and we don't think about some of these big questions, especially some with pain, because the pain takes all of the resources and energy. That becomes the center of the life versus who am I, and what am I supposed to do? What is my purpose here? So the hypnosis allows us to get to a deeper place within the individual And for people that have had pain or even traumatic experiences, they've never learned to be vulnerable with themselves. They've never learned to trust themselves. And as one of my patients has previously told me, the hypnosis, allows us to be, vulnerable at the deepest level, vulnerable with our souls. So it can, for many people, get to a very deep place that they maybe haven't gotten to because of the pain and everything else. So that's the second group. The third group is acceptance and commitment therapy. And this is, each of these groups builds on one another, builds on the skills. And what I tell people is, you're not going to feel less. You're actually going to feel more. We're just getting people good at feeling. The struggle with pain is that people try to change it. They try to avoid it. And one of the metaphors I love to use is most people try to put their pain in a beach ball. And this beach ball signifies all the depression, the anxiety, the pain, the trauma. And let's imagine that the person is in a pool and they try to get rid of the beach ball by pushing it underwater. Well, what happens when you push a beach ball underwater? Pops up and smacks you in the face. But again, we're going to get rid of this beach ball. We're going to control it. We're going to avoid it. We are going to eliminate it. Push it back down again, comes back up, same result. Now the person's getting frustrated. Their body's getting sore. So it's not the pain in itself. It's not the memories in itself. It's not the depression itself or the anxiety in itself that's causing the distress. It's what the person is trying to do with it. It's the relationship they have with it. That's what causes suffering. It's not all these other things. Depression, anxiety, pain, these are all parts of human functioning, part of who we are. We're not going to get rid of those things. But when the paradigm is get rid of those things, that's what causes people's distress and suffering. So that third group, acceptance and commitment therapy, it teaches patients that they no longer have to avoid. We spend the vast majority of our lives avoiding things. And we can avoid lots of different ways. For intellectualizers, thinkers, we avoid by fantasizing about how we're going to solve whatever problem, or thinking about all the things we should have, could have, would have done, right? We are constantly living in the past, which causes us to feel depressed, or constantly thinking about the future, which causes us to feel anxious, instead of being in this moment right now, feeling, sensing, smelling, our taste, our sense of smell, taste, touch, all of the things of living in the moment. Acceptance and commitment therapy helps ground people in the present moment to live their life in a way where they don't have to avoid anymore. You're making space for these things instead of spending effort and energy trying to change them.
Curious. So are there patients out there that show up with chronic pain and don't recognize that they've had trauma in the past that is preventing them from dealing with it? Or do they know that they've had it? Are people that have had trauma aware of it?
Yeah, great question. I think most people that have trauma are aware of it, but oftentimes they're not aware to the extent that it continues to impact them. Again, I'm going to go back to a renovation metaphor. If I'm renovating a house and I pull down a wall and I see that, well, that drain needs to probably be fixed. And then I start fixing that drain and realize, well, I need to change some electrical. And I pull that out, well, I need to change some drywall, right? My personal belief is that anytime that we continue to look, we constantly evolve, right?
Right.
We are always asking questions. We're always evolving, but some of us, we stop asking some of those questions. So there are always, I think there are always factors that are there, and some people are aware of how some of those traumatic experiences have impacted them. But I think it's probably a small number that are completely aware, because I'm not sure if one can be completely aware of how an event has impacted them in totality. But most people that come through our program that have gone through challenging life experiences, they don't have the trust. They're concerned about being vulnerable with other people. What they haven't realized is that it's really not about being vulnerable with other people. It's about, how do I be vulnerable from myself? We look externally for treatments. medications, other things, psychotherapy. People are coming to me to give them suggestions or interventions to heal themselves. And so what I'm teaching them is I'm giving them a framework to, here's a way that you can heal yourself from within. So you don't have to rely on other things to heal. You know, all you have to do is flip on the television and look at, you know, various advertisements about all the quick fixes. We are a quick fix culture, a quick fix society. And many of these things aren't quick. If somebody comes in my program, they're not going to expect a quick fix. I oftentimes will say, how long have you been thinking the way you've been thinking? And they'll say, my whole life. That's not going to change overnight.
Right, yeah.
You know, we're changing these patterns that have taken a lifetime. So, but by the time we get to the end of 6 months, 6 sessions of cognitive behavioral therapy, 6 sessions of clinical hypnosis. So we've reduced their pain. We've helped them have a stronger connection. And then we get to acceptance and commitment therapy. And we're really, interestingly, when we get to ACT, we talk less about pain. Pain used to be this big part, now becomes a smaller component. And now we're talking more about what are the things that you can do on a day-to-day basis that are consistent with your values? Because distress occurs when our behaviors are not in line with our values. Some people don't even know what their values are. So helping people be consistent with their values and knowing that, and again, this doesn't happen overnight, but a thought becomes a thought, an emotion becomes an emotion, and pain becomes pain, right? It's the story that causes the suffering. It's that we have become these things. So part of this is helping people distance themselves, or, you know, a good way to put it is put some space. One of the quotes I really like is, I try to help people live between the place between a stimulus and a response. Something happens, and typically, you know, let's say you're driving in traffic, somebody cuts you off, they're honking at you, your heart rate's up, you're already upset, you're going to be late. You have already responded without even knowing it. The vast majority of time, we are responding in life without even knowing it. So I'm teaching people that they get to choose. They get to choose what their response is to the pain. They get to choose what their response is to stress. We're not going to get rid of stressors. We're not going to get rid of the extreme weather we're having. We're not going to get rid of all the crazy things that are happening in this world. But what we can do is help people to control or have better control over, how am I reacting? How am I responding in that space? And oftentimes it's helping people to become connected with the here and now experience.
Yeah.
Most of us aren't connected with the here and now experience.
No, not at all. It's that whole happy wire between that stimulus and response that we miss out on that. But we really do. You know, I tell, as we were talking at the beginning of the podcast, my daughters are pretty athletic and they do a lot of sports. And, you know, sometimes when they have a bad, I say that doesn't define who you are. You know, that was just one game, and you missed a shot. That doesn't define you.
It was a moment.
Yeah, in time.
It was a moment in time.
And I will say they both have really good perspectives on that as they've aged. That, you know, this is just a, you know, there is a stimulus and response, and that doesn't define who you are. What percentage, if you can give a percentage,
Sure.
What percentage of patients get better?
Boy, I haven't had a patient that's gone through the program that hasn't had some type of
improvement.
Outcome.
Okay,
absolutely.
good.
So
good.
What does that look like? It's different for everybody. It could be decreased depression, decreased anxiety, increased functioning. They're doing more things. They're more engaged. They're avoiding less. Sometimes pain changes. Sometimes it doesn't. What people don't understand is that we have this expectation that for me to have a happy, enjoyable life, I must be pain-free. And part of what we're teaching is I can live a meaningful life. I can be engaged. I can be fulfilled and still have pain, right? The pain experience becomes different. It's the relationship with the pain. When people are not struggling with the pain as much, they're still going to have pain. Again, we're not going to get rid of it. We're learning a different way to relate to it. You're having a different relationship to it. So what I tell patients is, and I think some of my patients would say this, I don't believe that therapy should last forever. I know there are some providers that think therapy should be ongoing. I want patients to have my program. I don't want to see them again. I do have a monthly maintenance group where they can come back once a month to get some support, but I want people to live their lives the way they should be living their lives and not have to rely on me or a mental health provider to provide them ongoing skills throughout the rest of their life. Again, we want the change to be able to come from within with people. So when people go through the 6-month program, yes, they're less depressed and maybe have less pain from hypnosis, and they're feeling better and they're doing more things, they're more engaged, they're more active, they're more meaningful. But many of them are different people. They're not the same person. And I tell people that's a risk, because once you start thinking about things differently, and it's not just thinking about pain, to be quite honest, the pain is the hook to get them in. It's really helping them have a different paradigm about life. Their life becomes different. Again, it's the difference between walking around and living your life with these blinders on, how we're thinking and feeling and all this, versus, wow, this is what life is about. I'm feeling all these things. Life is more fruitful with pain. So lots of different outcomes. And the biggest outcome is that people are different people at the end. They're not thinking the same way. They're not feeling the same way. Some still have pain. Many have pain. Some of their pain is decreased, but the pain is having a less significant impact on their lives, and they're still able to live a more meaningful life.
We do go through life rather thoughtless about life, right?
We do.
That must be some sort of coping mechanism somewhere. So, how can patients learn more about this?
Yeah, again, we'd love to see it. Many of my patients have had psychotherapy in the past. So if you have a counselor, you've done this work and you think, well, I've already done this. This is a little bit different than what you've had. Patients, or this is a group setting. Again, I'm not sure. It's my personal belief that I'm sure patients could probably get to the same place with individual counseling, but I've had patients that have come in that have had counseling for 15, 20 years, and they haven't got to the place where they needed to get at. It's really only through a series of these tiered programs over this period of time to get to where they want to be. So if they've had counseling, we'd love to be able to see them as well. Oftentimes I've got patients that are in our program that have counselors, but the best way is to give us a call. It's 319-368-5992. It's our St. Luke's Rehab and Pain Center. Schedule a 30-minute evaluation session with me, or the entry point into our program is a 90-minute class where I talk a lot about the same things that I'm talking with you. Once people come to that class and they learn more about what to expect, and at this point, what do you have to lose? If you come to the class, you don't like it, you're out 90 minutes. But I will say that the vast majority of people that come enter our program, and once they've entered our program, they work hard. This is difficult. This is more challenging than going to a provider and getting a medicine. There's homework assignments. We're going to ask you to change your thinking and behavioral patterns, and we are creatures of habit. We don't like change. Change is hard, but for many of the patients that I see, they're ready to make some changes. So if you're ready to make some changes and you want to get your life back, give us a call. Again, 319-368-5992. We'd love to see you in our St. Luke's Rehab and Pain Center.
The phrase, change will happen when remaining the same is more painful than the change, and that's where we want to get our patients, that they can see the proverbial light at the end of the tunnel. Dr. Tallman, thank you again for joining me. It's always great to have you on the show. Once again, this is Dr. Benjamin Tallman, pain psychologist with St. Luke's Rehab and Pain Center. To learn more, visit unipoint.org.
Thank you for listening to LiveWell Talk On. If you enjoyed this episode, don't forget to subscribe. And if you want to spread the word, please give us a 5-star review and tell your family, friends, neighbors, strangers about our podcast. We're available on Apple Podcasts, Spotify, Pandora, or wherever you get your podcast. Until next time, be well.